I have a lot of patients who I say, what are your birth preferences? They're like, I just want a healthy baby and a healthy mum. But and that's what in obstetrics we've always thought that's the priority. But obviously that is not enough. Yes. That's what the inquiry says. It's not enough to say healthy mum, healthy baby. Yeah. People are women, they're going through an experience and they want it to be the way that they want it to be, and that's fair. It's their bodies.
Hi everyone and welcome back to No Place Like Home. I'm your host Larissa and I am graced today with Ms. Kath Taylor, or Mrs. I should say, Kath Taylor, who Kath, if anyone doesn't know, is our Director of Ops and registered nurse here at Homb. So I'm super stoked to have Kath in today chatting with us. And we also have the pleasure of Dr. Perri Dyson here with us. We are going to talk a bit today. I'm just going to do a bit of a trigger warning because some of the topics that we're going to talk about today may be quite triggering for some people. So we're going to be talking today primarily around informed consent, and we're doing this in referencing the birth trauma inquiry. So I really value you being here today, Dr. Perri. We haven't had an obstetrician on before, and so I think it's a great opportunity to hear the voice of an obstetrician on this topic, because I feel like I certainly have heard a lot from, women's voices and their experiences. So I'm really interested to talk to you today. But first, tell us a bit about yourself and your qualifications and your journey into motherhood.
Great. Well, it's a pleasure to be here. Thank you for inviting me come to speak.
You're welcome.
I'm an obstetrician and gynaecologist, and I work in a multidisciplinary women's health practice. So we have 5 obstetricians, and we share after hours on call for our private patients, which means that we are able to have time with our families, but also have continuity of care with our own patients. And our patients are able to have met the other 4 doctors during pregnancy, and therefore if they're the ones who are on call when a patient comes to give birth, they've met them before, which I think is really great for people.
Okay. Yeah, that is great.
And I think we might touch on that later in terms of continuity of care.
Absolutely.
And our practice also has got 3 other gynecologists, and 4 physiotherapists who do women's health and pelvic floor physio. We have an acupuncturist and Chinese medicine specialist.
Amazing.
Dietitian, lactation consultant, and 4 midwives. So
what's the clinic
really
called?
Great. Oh,
we're everyone out there.
Plug it. Obstetrics and Gynaecology Consulting Group. Okay. Yeah, and our practice is in North Melbourne.
Okay.
And I should say that the things that I will talk about today are my opinion and not of the hospitals and people that I work with.
Yeah, absolutely. Yeah. It's information.
Yeah.
Not advice.
Yeah.
So what does the care look like in that clinic? Is that like from the moment you conceive? Or is there
for pregnancy care, if someone comes to see us, they are booked with 1 obstetrician, so they will come and see me, and I will see them for most of the appointments during the pregnancy, but they'll have 4 other appointments as much as we can schedule with the other 4 obstetricians so that they're able to meet them during the pregnancy.
And create that relationship.
Yeah. And it's only 1 appointment, but at least if they've had a chat and
it's not unfamiliar.
Got to see how the other doctors work. Although we do all have similar philosophies in terms of birth practices, which is really important.
Yeah. You're a mum yourself. Before we get to that, did you always want to be an obstetrician?
Yeah. Well, once I started medicine and became and when I was a medical student and did a rotation through obstetrics, I fell in love with it and never thought of doing anything else after that.
Yeah, there you go. Yeah. Tell us about your journey through your own motherhood.
Yeah. So I've got 3 children. They're 16, 14 and 8. But I've had 6 pregnancies and the first 3 were all pregnancy losses. And so it was a hard couple of years getting to that first child. In my first pregnancy, I conceived when I was in my second last year of O&G training.
Right. Yeah.
And the pregnancy was all going very well, and then we found out that the baby had trisomy 18, which is a severe chromosome abnormality.
Right.
And we lost the baby at 13 weeks, and that was really hard because even though it's only 13 weeks, already at 13 weeks and even 6 weeks, we're already making plans.
Of course you are. Yeah.
Yeah. And after that, I conceived quickly, but I had 2 miscarriages that were quite early. Yep. And so at that point, it's a hard, particularly when it happens before you've had your own children, I think, because you wonder, am I ever going to be able to have children? And I think my empathy in my work at that point was quite low. People, when they're pregnant, have complaints that are valid, heartburn, nausea. They can be terrible. And in my mind, I'd be like, at least you're pregnant and you know you've got this far in your pregnancy. And so that was a hard time. And I think for a lot of people, and for me, the only thing that cures that is having an ongoing pregnancy and then having a child.
Of course.
Yeah. And then luckily I had my 4th pregnancy, which was all fine. At the end of pregnancy, I developed cholestasis of pregnancy, which is a liver condition which causes quite bad itching, and it can be associated with the placenta not functioning very well. And so obstetricians would generally recommend having the baby around 38, or in that time around 38 weeks.
Okay.
Is
that just because
of risk of stillbirth?
Got it.
Because the placenta sometimes stops working at that point.
Right.
Yeah.
Okay.
Yeah.
Okay.
And I only found out I had the cholestasis the week before when I was really itchy. I had blood tests that showed I had this condition. I was seeing a private obstetrician through all my pregnancies, the same one. So I was lucky that I had that trust in her. And we agreed that I should be induced. I was excited about that. I was ready to have a baby after 2 years of waiting to have a baby and good, let's have this baby before something happens, you know.
Yeah.
Do you feel like that's heightened? Well, obviously it is heightened because you have had those previous experiences.
I think it certainly did at that time.
The prospect of induction is not.
And also because I'm an obstetrician and I know what the process of induction looks like. It never was something that I was afraid of. I was like, good, I get to experience this, you know. I had a curiosity about what that feels like. And I know it's different for everyone. But for me, that was like, okay, let's see what it's like to have Prostin gel. You come in the night before, you have the gel put in.
It's almost like
you start to have contractions. You're like, oh, good, I get to feel what a contraction feels
most
like.
significant work experience that you could actually have, you know.
Did you have much control over, like, what that birth experience was like? Like, did you have any input in that with your knowledge that you brought to the table about what that looked like, or were you led into that and trusted your?
I think for most people who are induced for their first baby, the recommendations for them, like the mode of induction is going to be similar. So people come and have gel or a balloon the night before and the next day they have their waters broken and they have a drip with Syntocinon. And that's all I knew and I was happy with that.
Throughout were all of your pregnancies were all of your births similar?
No, they were quite different.
Yeah.
So I was induced with my first and I had done calm birthing, which is a form of hypnobirthing. And I used those skills in labour and at 2 centimetres I couldn't cope anymore. I tried the gas, tried the morphine, had an epidural, loved the epidural. Got to 8 centimetres, baby was stuck in the posterior position, which is looking up at the roof, which tends to make labour a little bit slower. Got stuck at 8 centimetres, had an unplanned Caesar.
Right.
Yeah. And I was a bit disappointed for about 10 minutes.
Yeah.
And then I'm like, here's the baby, and that's nice. And
Yeah.
And my recovery was fine. I breastfed well. I was lucky I had good milk supply, and I had good support from my husband and my family. So things were good. And at that time when I'd had the baby, I said, I don't need to do this again. That was long and that was hard. But then when I got pregnant the second time, I said, no, I want to have a vaginal birth on try. Yeah. And so with the second one, I did have a vaginal birth.
Oh, amazing.
And so I got to have that experience as well.
And were you induced or did you
No,
go
I just went into
natural?
labour on my own.
And so for
that
you,
was good.
did you keep could you it feels like completely opposite, really as far as things go? Were you okay, I've experienced both now?
Yeah. I think the actual birth is completely different. The actual giving birth is different. The labour's similar.
Yeah.
My calm birth skills actually got me through that time, which was great.
Yeah.
Because it's, not as long.
Yeah.
And he was a big baby. And I do wonder, because when I'm talking to people who are asking about having a trial of labour after caesarean, from an intellectual point of view, think, why do people want to do that so much? Why do they want to try and have a vaginal birth? Because in many ways the safest thing for the baby is to have another caesarean, and for some mothers as well. But it wasn't until I was there myself that I thought there's something that I can't explain that want to try and have a vaginal birth. And maybe it's because we grow up as girls growing into women thinking that that's what we're going to do and that's what's normal. I don't know.
Do you think it was linked at all with your disappointment that sort of briefly skirted around you after a caesarean that made you want to go, okay, maybe that's still there?
And I think maybe it was also to do with I've looked after all of these women and seen them give birth vaginally, and again about just wanting to try that. I want to try new things. I want to try that.
Yeah.
I had some regrets afterwards because I had quite bad pelvic floor damage and I had some urinary incontinence. And then I thought, maybe I should have had a caesarean.
Yeah.
I don't know if I would have done it differently though. Yeah. And then I had another vaginal birth, which was very quick with my third.
Yep.
And after him, I had incontinence surgery.
Right.
Because I was not able to run and do aerobics, and I'm quite active and I love to do those jumping up and down type exercises, and that was when I would have urinary leakage.
Right.
And that fortunately has fixed the problem.
Okay.
Yeah. But I think also that has coloured the way that I counsel people in terms of
that's what I was going to I was curious about that because I think it's quite a unique, I think there's so many male obstetricians that don't and will never understand those intangibles. Like you just said, there was something in me that just needed to have that vaginal birth. That's something that, you've experienced that as a woman, and then to be in that profession as well, and for a woman to sit in front of you and say that, you will intrinsically understand that.
Yes.
You will absolutely get that.
Yeah.
Despite knowing
despite knowing the medical components of it and advice and information that you probably feel like you need to give, there's also this greater empathy that male obstetricians just won't ever have. And that's just the reality.
Perhaps. But of course my experience is only one experience and it's different for everyone.
Absolutely.
And another obstetrician who gives birth might feel differently about that as well.
Yeah.
I guess from the perspective of if we're thinking about postpartum, what did that look like for you and did you plan for that with any of your babes?
I'm a big planner.
Yeah.
I did a lot of reading before the first.
Yeah.
But but I followed the recommendations at that time in terms of demand feeding and it went well. And I think for my patients who struggle postpartum, a lot of it is to do with breastfeeding being difficult. And so I was lucky in that regard. Yeah.
Okay, let's jump into the big topic of informed consent.
Yes.
I think, as an overarching, and Rach, our producer, will hate this because she hates it when I go rogue, but I'm just really curious, as someone who's in the profession, and when this birth trauma inquiry came out, how did that feel for you? Like what are your feelings around that?
Yeah. Well, I would like to say that I felt and I feel really saddened by all the people who have reported birth trauma and really glad that people felt like they were able to come out and speak to the inquiry, and also professionals who work in the area of childbirth were able to speak and give their opinions through that. And reading through it, I'm not sure I've read all 250-something pages.
Yeah.
It's chunky.
Reading through it, I did feel a bit of a slap in the face. There's some sort of anti-establishment type comments that are made, and I think none of us working in maternity care go into it to cause birth trauma. We go to work each day and we're trying to do our best. And when people say, that was really you're like, oh, my God. Have I been doing these things? Have I been saying things that have been upsetting people? And so that was hard. But it's obviously a huge problem.
Yeah.
The statistics are there.
Yeah.
And so there are things that we are not doing right in maternity care.
Yeah.
And I think that some of that is communication.
Yeah. So what does that look like for you? What's like adequate information sharing, I guess? Like what does that look like during like your care with somebody?
So it's a little bit different in private versus in the public space, but in the private, because I've got continuity of care, then I know exactly what people are reading and learning, as in they will tell me, we'll have time to talk about that. I can schedule longer appointments to make sure those things are covered. But the patients in our practice, we also run an antenatal class in our practice with one of our midwives and physios. And so we know that they're covering what the normal stages of labour are, what possible interventions might happen, and the physios talk a lot about birth skills, positions in labour, how partners can support their birthing partners. And we direct people to the College of Obstetricians, Ranscog pamphlets, which talk about a lot of those topics as well. And then in later pregnancy, I give all my patients a birth preferences form, which they fill in, and then they come back and talk to us about it, so that it's mainly as a prompt for discussing things like, if this happened, would you feel comfortable having an episiotomy?
Yeah.
And so that we really just want to make sure that people understand that if you're planning to have a vaginal birth in particular, that it's not necessarily going to be all smooth sailing, normal birth. And a lot of my patients will say, I want a low intervention birth, I don't want to have an epidural. But the reality is that the vast majority of women in their first pregnancy will end up choosing to have an epidural, and that 25% will end up having an instrument-assisted birth, and that 30%, 25 to 30% will have an unplanned Caesar. And if people don't know that, then it's much harder for them to cope with afterwards. And so in terms of education for my patients, I want to make sure they've got some realistic expectations about what labour might look like.
And then do you encourage, as a part of that information sharing, do you then encourage them to go away and sort of find their own research or their own readings?
And of course, most people are also reading
Yeah.
like Juju's birth skills.
Yeah.
I recommend a hypnobirthing
Yeah.
course because I think you need to have skills when you go into labour. And
Yeah.
a lot of people think, I'll just go with the flow, but you do need to have some skills when you're going into labour.
Yeah.
Yeah, definitely.
How much of this do you feel is relationship building and having your like patient trust?
That's the other thing. The trust is really important.
Yeah.
And so sometimes our patients are going to be giving birth with one of the other obstetricians.
Yeah.
And like I said, at least they've seen their face. And it is nicer for us all as practitioners and as patients if we have met each other before and spent more time with each other. But if we've had those conversations and hopefully they feel like I understand where they're coming from.
Yeah.
And one of the things from the birth trauma inquiry was about trauma-informed care, understanding about people's past experiences, particularly if they've had traumatic events happen to them or sexual abuse, for example.
Yes.
Then I think that's important that people are able to feel comfortable in making a plan. And that might be they're saying, this has happened to me in the birth suite. I would like it if people don't just come up and touch my tummy.
Yeah.
And so, just making those sort of plans that are appropriate for people. Yeah. So I think the trust is really important. And then if I have to recommend something like a rapid instrumental birth because I'm worried about the baby's heart rate, it is much easier because people have already had that discussion and I know that they've already had a discussion about the risks of the procedure.
Yeah.
And hopefully they feel that they can trust my opinion on that as well.
So I guess we've talked a little bit about what informed consent looks like potentially beforehand. So there's a fair bit of work and education that goes into that.
Yeah.
What about the during and the intensity of birth? Like you're talking about like, some of the things that can potentially go wrong. Like what does that look like for you in an emergency situation? Or maybe it's not emergency, maybe it's just blow by blow.
Yeah.
Like,
well, I think we talk a lot about emergency Caesars, but for example, or emergency instrumental birth, most of the time it's not that emergent as in usually there's a little bit of time to discuss things.
Is that term just sort of thrown around?
Sometimes there's not. And there certainly is, frequently times where we feel like, we haven't got much time here because the baby's heart rate has dropped and it's not coming up.
Okay.
And that's the sort of situation that I think it's good if we've sort of prepared and had those discussions about beforehand.
Yeah. Mm-hmm.
But most of the time, an unplanned Caesar for most people is the cervix has got to a certain point, it doesn't seem to be dilating anymore, or the baby's heart rate is not very reassuring, but it's not, has to be done this minute. And in that case, there's time to discuss and there's time to discuss options of different management, waiting a little bit longer, things like that.
And it feels gentler instead of sort of this, red lights, alarms sort of environment.
Yeah, exactly. And if we can anticipate that perhaps the baby's heart rate is looking we're a little bit worried about it and they're getting close to being the pushing stage, we might say it might be at some point that I would recommend doing an instrumental assisted birth. This is what that might look like. So there's been a little bit of discussion beforehand. But sometimes I really think that we need to get this baby delivered really quickly. And so we're talking at the same time as setting up the instruments and asking a woman to have her legs up in the stirrups. And that's hard.
Yeah.
But it is easier if the discussions have happened beforehand.
Yeah. So
And I
the
think-
prep like in that pregnancy phase throughout, so they've got a fair bit of education. Assumably most people are thinking, oh, that's not going to happen to me. But
Yes.
so maybe some of it they're switching
that,
off.
I think that is a thing.
Yeah.
We all have that, don't we?
Oh, for sure.
Yeah.
That won't happen to me.
Yeah.
Yeah.
Because otherwise we would be living in a constant bubble of anxiety.
Yeah. I guess like from your practice, it sounds like you're doing a lot of talk. You're doing the
lot of
talk
education.
beforehand
Yeah.
so that people are building those relationships and trusting the information you're giving them. It sounds like you're doing the talk throughout.
Yeah.
From this inquiry, I feel like potentially there's a communication barrier. And I know you can only speak of your own practice.
Yes. And I think like my practice is only a small subset of people who are giving birth, as in terms of with private continuity of care with a private obstetrician. And that's the other thing that came out of the inquiry was that there needs to be more continuity of care or continuity of carer models with midwife or obstetrician. And I certainly feel that it is different in my public hospital work in terms of in the antenatal clinic, it's rushed.
Yeah.
The appointments are booked for me. Sometimes I've got 15 minutes to meet someone I've never met before. And it might be that they're 38 weeks and I'm advising being induced for a medical condition. I've never met them before.
Yeah.
It's hard to get the trust in that situation. And they might say, oh, why should I trust you? I've read on the internet that obstetricians are interventionist and so that's hard in the antenatal clinic. And also we don't have a lot of time to go through people's birth preferences and birth plans. And we do get complaints that people can't access antenatal classes because they're all booked out or they can't afford them. That was another thing that came out of the inquiry is about having more affordable or free antenatal education classes. And then when I'm working in the birth suite, then for the vast majority of women that I see, the first time I meet them is when I am going in and talking about an intervention such as an unplanned Caesar.
Yeah, so so potentially you're that bad guy, despite the fact that, you know, in your private practice you've had that time to build a relationship and like have that banter between you that says, I know what you want. I've got your best situation. Best interest at heart.
Yeah.
That must feel like the polar opposite, even though assumably sometimes you can probably predict the outcome. Can you? Or is all birth different?
It's really hard to predict.
Okay.
Yeah.
Yeah.
I think we all say that in obstetrics and midwives and obstetricians. We go, whoa, we should know better now that you can't assume anything.
Yeah.
And people get sent home from hospital thinking they're not in labour and they're back giving birth in 20 minutes and anything can happen.
Yeah, okay.
Yeah.
So that's hard as it is. That's the, you know, that differentiation between, you know, private and public and what that feels like. You work in both. Your care is the same, yet it's the relationship that sounds like a really important thing. And you're trusting your predecessor who's seen them.
It's so much harder for the patients who are giving birth. That they haven't met the midwife before when they're giving birth. They may not have been able to discuss their birth preferences until they're in there in pain, which makes it harder to have the discussion.
And that then is the cascade of that intervention probably because things are happening, it feels rushed, it feels a bit panicked, and then it just feels like it all probably escalates from there. I mean, we always say, particularly here at home, like it's really hard to articulate when people don't know what they don't know. Right? So how do you find that balance of sharing enough information about the risks that come at a time of birth and pregnancy, but also not like we've been doing this for eons.
Yep.
How do you find that balance of empowering a woman to trust her body through that process, but then also outlining the risks of what you know and not scaring people into, you know, almost having their body have that resistance because of that information sharing, but then also trying to, you know, give them that.
And I think there's a legal side on that as well.
Yeah.
And that there's a legal obligation to make sure people have been told certain risks
Yeah.
and to have documented that, which has become stronger over time.
Do you think
It's
that
interesting.
skews your ability to be able to provide?
I used to think so, but I think actually now women do want to know those things. And I think in the past maybe 5 to 10 years there's been a shift in thinking where people before, perhaps obstetricians were blamed for being a little bit too fear-mongering. And I think now people are recognising that as a woman and as a patient, actually I want to know that. I want to know that I have a risk of incontinence after having a vaginal birth. And there's certainly ways of doing it better than others and having that conversation. We're actually in our practice just drafting a written information for birth in general, which talks about the risks of caesarean section, the risks of vaginal birth, if you have an instrument-assisted birth.
Yeah.
When we first drafted this, my colleague was tasked with drafting this. We all read it and went, oh, my God, no one is going to want to choose to have a vaginal birth after reading this.
Yeah.
We have to go and change it.
Yeah.
And so she's reworded it and it's much nicer, but it's got all the facts there and it's got figures there. And maybe, like you said before, maybe we'll read those and go, that won't happen to me. But the information is there. Yeah. And I think, again, it's a talking point to come back and talk in the clinic to people about if they say, well, I'm worried about what you said here.
Yes.
Yeah.
Yeah, I understand that.
Yeah.
There was one point that stood out to me from the report was the issue of hospital guidelines and policies being written in ways that mandate routine interventions. Is there an evidence-based reason as to why these guidelines are in place? It seems to be consistent with Victorian guidelines.
Yeah. All hospitals, have got guidelines.
Yeah.
And when I read that in the inquiry report, I don't like the word mandate. I think guidelines are guidelines, and in the hospital we do see them as guidelines, particularly in a public hospital. We've got a lot of junior midwives and junior doctors, and they may not know what the standard recommended medical recommendation would be in different situations. So if someone has broken their waters and they're not in labour, there's a guideline which helps to give us and to be able to give the patients advice based on the best possible evidence, or the best available evidence. And sometimes that evidence is not as good as at other times. But I think a lot of the guidelines are evidence-based, and I don't see them as mandates so much as I would go in and say to a patient, in this situation, this is what the guideline is recommending, but the patient in the end can say, I understand that, but I don't want to be induced in 48 hours. I want to wait till my body goes into labour, and I understand that there is a risk of infection, and that's fine. I think sometimes, particularly as junior staff, and I remember as a junior it was harder, I think I'm better now at sort of letting if people are declining the sort of routine or recommended management, then that's okay. I let it flow over me. Whereas I think it can be harder when you're younger and you're like, well, what if something happens? And if something does happen, it's awful, and it's awful for everyone. And we think, well, why that this could have been different.
How do you make sure that parents-to-be have, or like, you know, throughout birth and pregnancy, have the information that they need to either trust in what you're offering or to make the decisions like with a clear head? Can you?
I don't. I think we do our best. And we can, like I've said, we can do better with putting all that information out there. But on the other hand, there is a whole lot of information out there which is perhaps not useful as well. So on the internet, people are reading about this is the right way to do things and this is the right way to do things. And perhaps they are for some people, and perhaps they're not the right way for me as an obstetrician, and I don't agree with those things, but that doesn't make them the wrong way to do things.
Yeah,
but I think people feel like they have to, because the information is out there these days, it's like also as a parent, it's like we should know how to do this, this and this. And if we don't, then we're letting ourselves down as parents and letting our children down. We can't know everything.
No.
Just because it's on the internet, and false news is out there.
There's such a
Not
Zoom.
going to get on to Trump today.
No.
Oh, no, rewind.
It feels like there's such a zoomed in view at the moment of birth and what birth trauma looks like. It feels like each individual knows what they want for themselves, and anything that isn't happening, well, that doesn't happen that way, was traumatic.
Yeah, for some people.
For some people, correct.
And I think I have a lot of patients who I say, what are your birth preferences? They're like, I just want a healthy baby and a healthy mum. But and that's what in obstetrics we've always thought that's the priority. But obviously that is not enough. That's what the inquiry says. It's not enough to say healthy mum, healthy baby.
Yeah.
People are women, they're going through an experience and they want it to be the way that they want it to be, and that's fair. It's their bodies. And
And I suppose that's where the education piece comes in, isn't it? Because that umbrella statement, we know that the more informed that new parents are, then it enables them to make more informed decisions. So I suppose the next big thing that was in the report was coercion. And, you know, I think there was this overshadowing of that it felt quite heavy throughout the report of this coercion.
Yes. Yep.
Well, what are your feelings around that? Like, you know, I know I've certainly heard a lot of stories from women that stay here and have come, you know, straight from hospital to stay with us, that they certainly do feel like that they have been coerced into certain things, and it has been framed to them that it's an emergency situation when, you know, the after fact, they're like, well, actually, I've spoken to so-and-so and it probably wasn't, and I could have done this, but those options weren't provided to me, so they feel like they were coerced. How does that feel for you, I suppose? Like, what are your feelings around?
I do think we have to recognise as clinicians, midwives, doctors, anyone who's dealing with patients in general, that we have biases, and for that might mean that I think the right course of management is to do and have an intervention.
Yeah.
And I need to recognise that is my opinion based on my training and the evidence that I use, and that another practitioner, for example, a midwife who is anti-intervention or not interested in intervention for speeding up labour purposes, for example, will have another bias. Yeah. And that's also a bias. It's a bias in a different direction. And I think
you then manage that, doctor? Like if you are in those, because ultimately the best decision needs to be made in conjunction with that birthing person.
Yes.
And that woman that's there.
Yeah, yeah.
How do you as a practitioner manage those conflicting opinions and advice in that potentially emergency situation where you would have one person saying one thing and then your biases are another thing, and then you might have someone else who's completely different? Like what does that look like for women that are birthing?
The stories from the inquiry are – some of the stories from the inquiry are awful in that regard. And perhaps I've been guilty of that also. I don't know, in the past. I think on on a day-to-day level, if I see someone in a certain situation and I think that is the right course of action, then I will usually say this is what I would recommend.
Mm.
And I hope that I'm also able to say at the moment this is not an emergency. This is not the only thing that has to happen. There are other options.
Yeah.
Yeah.
In the end, it's up to you.
Yes.
Yeah.
Yeah.
And I think again about the biases, we all need to sometimes stand back from our practice and say, is this the right thing to be saying?
Yeah.
I guess the inevitability of things often, whether it be emergency or other, that things are traumatic, whether it's to the actual person themselves experiencing it or the practitioner. Obviously, we know the importance of birth debriefing and what that looks like, and there's a lot of talk around that for the patient. What does that look like for you as a practitioner?
Yeah.
Is that happening?
Yeah, and I think it is happening now, but previously it wasn't so perhaps institutionalised, or it wasn't something that happened as a routine.
Yeah.
And now if there is a birth situation where there is a bad outcome or a difficult outcome, then we do a hot debrief, which is talking immediately,
Right.
over the next few hours to 24 hours about what has happened and how everyone feels about what happened, because it can be really hard when those things happen.
Yeah.
Yeah.
It's obviously the hardest is for the patient themselves, but it is hard for us practitioners and then to go back to work
Yeah.
the next day.
Yeah.
And we do, I think it's bi-monthly get-together where we can talk about
Amazing.
experiences that were harder. In our private practice, we have a debrief amongst ourselves where we say, oh, this is what happened, and give opinions to each other. And
I certainly know we hear it a lot from midwives, both midwives that work here at home, but then also just generally midwives that approach us, to work with us or, whatever it is. And there certainly doesn't seem to be adequate support for midwives and what they witness and experience. So it's good to hear that, within your practice, you provide that support for each other, which I think is just so important. So last final question, Doctor. What do you think out of the report and the recommendations that were made for you, what do you think are the fundamental things that need to be put in place?
Yeah, I think we've probably talked about the main ones, but instituting from the recommendations that came from the inquiry, there were lots and they're all important, but the ones that stood out for me that sort of, gel with me resonate with me are continuity of care or carer models, really important.
Yeah.
And antenatal education so that people have got realistic expectations about what can happen in birth. I think those are the two big things for me.
Yeah.
Yeah.
They're certainly ones we've spoken about today, that communication and consistency in building those relationships and trust. It feels like that's been a theme of what you've spoken about today. So much easier to do in a private practice scene than a public, but trusting that the right information.
But it can be done in public, I think.
Yeah, I was going to say to you, what in the public system,
and certainly in other jurisdictions, in other countries. I know in New Zealand they have much better continuity of care models.
It's wild that we just don't learn from other countries.
Yeah. It's the money thing as well. I mean,
it's always the money thing. That's the problem.
Yeah.
Anyway, well, we won't. That's another podcast. Thank you so much, Dr. Perri, for being with us today. I've really valued the chat and that different perspective as well. I think it's really important to hear all voices on all sides of pregnancy, birth and postpartum. So thank you very much for being with us.
Thank you.
This podcast represents the opinions of our hosts and their guest speakers. Views and opinions expressed in the podcast are our own and do not represent that of our places of work. This podcast is for informational purposes only, and content here should not be taken as medical or professional advice. Please consult your healthcare professional for any personal recommendations and medical care. While we make every effort to ensure that the information we are sharing is accurate based on the best available information at the time of recording, we welcome any comments, suggestions or feedback via our website contact form, homb.com.au/contact. Names and details of personal experiences may have been changed to allow for anonymity and privacy. To join the conversation, join us on social media at Homb Postpartum.